to our executive webcast series around care coordination. My name is Guy Mansetto. I am a co-chair within the PCC Center for PCMH Advancement. Last year, I had the honor of working with my fellow co-chairs within the center. I was involved in the task force that examined the role of care coordination as it relates to the patient-centered medical home. The task force also included Julie Shields, Program Director of the Patient-Centered Primary Care Transformation Project at WellPoint, and Karen Mosley, Research Director of Care Continuum Alliance. And through the help of Help to Resources, the final report featured several elements. First was expert-authored articles on the definitions, role, and function of care coordination, as well as tools for implementation and measurement and monitoring of its effectiveness. In addition, there was a market scan which resulted in many case examples from PCMH sites across the country and a summary of survey responses from selected practices. I am very excited to introduce to you the first of 3 webcasts dedicated to this topic and to that guide. Today's presentation is entitled Supporting Care Coordination within the PCMH Model, presented by Dr. John Sideroff, Principal of Sideroff Health Solutions, and Dr. James Crawford, Chair of the Department of Pathology and Laboratory Medicine and Senior Vice President, North Shore, Long Island Jewish Health System. Dr. Sideroff is a general internal medicine physician with over 20 years of experience in primary care, disease management, and population-based care coordination. Dr. Sideroff has had numerous peer-reviewed publications. He's the author of a widely read disease management care blog, and is a board-certified internal medicine and is a fellow of the American College of Physicians. Dr. Crawford is also joining us. Directs and coordinates all components of pathology and laboratory medicine departments and provides strategic leadership of the laboratory service line across North Shore, Long Island Jewish Health System. Dr. Crawford is a member and has served in various leadership capacities, including Association of American Medical Colleges, College of American Pathologists, and the United States and Canadian Academy of Pathology. A couple of housekeeping items before we get started. All lines have been placed on mute to prevent any background noise. There will be time at the very end of the event for Q&A, which you will be using the GoToMeeting controls. At the very bottom portion of the GoToMeeting controls, you'll have an area to actually submit questions electronically. We will be polling participants throughout the webinar, so please take a look at your controls to participate in this interactive portion of the event. And at this time, it's my pleasure to introduce to you Dr. John Sideroff.
Great, thank you everybody, and welcome. My presentation today will be introducing and laying the track, if you will, for the notion of care coordination within the patient-centered medical home. And what I'd like to do is describe an approach to care coordination called population health management. And I won't spend a lot of time doing that, and then I will move on to the key ingredients of population health management which may advance care coordination within the PCMH. While I'm at it, I'm also going to review the evidence that those elements of population health management actually saves money over and beyond the investment that you need to make in the program. And then I'd like to review those quick, what I describe as quick hits, the specific items within population health management that people ought to think about when they're incorporating them into a patient-centered medical home, and then I'll close on what's at stake. And my goal is to get this done in half an hour so that we have plenty of time for questions. You know, there's a definition for population health management out there, and I'll march through this very quickly. I mean, it's population-based. I mean, whether it's an accountable care organization or whether it's a clinic, whether it's a hospital, or whether it's a primary care system, the fact is that increasingly we're being called to be accountable to a population and drive outcomes on that basis. And everyone agrees that care, those outcomes need to be proactive, accountable, patient-centric, needs to be physician-guided, enabling informed and activated patients so that they become members of the healthcare team, and as I mentioned, there needs to be teaming that includes the patient, and population health management rests on 3 core principles, which you can read here. Keep in mind that they all really focus on the role of the primary care physician, the role of the patient, and the use of teaming to drive not only care coordination but wellness and prevention. And you can find all this at the Care Continuum Alliance website. All well and good. I mean, these definitions make a whole lot of sense, but how about some graphics? Well, here's one graphic that I find helpful. It's kind of complicated, which is why I kind of prefer to show in my own presentations the following 2 slides. Now, as a doctor, when I grew up in the course of my training and for many years, this was the world according to Dr. Sidorov. It was the purpose of the healthcare system to arrange resources around me so that, you know, the triage system, the medical records, the nurses, the money, all came to me, and by taking good care of me as the doctor, the patient would come in one end and come out the other end in better shape than when they came in. There is a whole host of data and many studies that indicate that while this used to work pretty well, it doesn't work well enough. And there's plenty of data, as everyone on this phone call probably recognizes, that indicate that this particular style of care has many shortcomings associated with it, which brings us to population health and the patient-centered medical home, where a population, and the population can be assigned by a variety of methodologies. It could be a population that's assigned to a clinic. It could be a population that is being managed by an accountable care organization. It could be a population that's that is risk assigned to a managed care organization. Becomes the focus of attention. And the purpose of the healthcare system, if you will, is to array all resources around that population to drive outcomes. Now, everyone recognizes that the medical home is an important resource. I prefer to think of it as one resource that surrounds the population, because ultimately it is about the patient. And the other thing I'd like to point out here is that there are additional resources that are being applied. Disease management, case management, care management, our information systems, the electronic health record, and self-care. Now, we call it population health management, but I think a lot of folks on the phone call are going to recognize that the pedigree here is ultimately, quote, disease management. So the question is this population health management stuff, is this disease management stuff just a pig that we put lipstick on? You know, disease management has had a number of studies about it. It's been recently examined by the Congressional Budget Office, and a lot has been found wanting. So does it really work, and does it pay everyone on this phone call to really listen to me drone on about whether or not disease management, aka population health management, really does work? Well, you know, it turns out that in the last 2 years there have been some studies that indicate that the newer versions of, quote, disease management, unquote, or population health management out there really do have a return on investment. And this is one study that was reported in the New England Journal of Medicine. This was performed by a disease management, quote, vendor, service provider, if you will, looking at the impact of its telephonic outreach to patients with chronic illness that were assigned to an insurer. And these are statistically significant differences in healthcare costs per member per month that were seen compared to a control group. So, you know, there were savings achieved. The bar sticking down indicates negative numbers, so we're talking about $6 per patient per month in terms of savings on inpatient hospital. You add that up over thousands of patients, over many patient months, and the savings become quite significant. The savings become quite significant. This is a study that was done in a Medicare Advantage plan. It was reported in the American Journal of Managed Care. This is a difference within differences study indicating that the intervention group, way over on the left, N equals 462, had a bigger drop in healthcare costs compared to had a bigger drop in inpatient admissions compared to a control group. and admissions also related to diabetes. This was diabetes disease management. Also resulted in reduced admissions. Once again, this managed to achieve statistical significance, and there were some significant dollars attached to that. With fewer inpatient admissions, there were significant savings, and it was quite impressive. And this is a study from another type of commercial plan, although not really commercial. It's TRICARE, it's government. But I call your attention to maybe 2/3 of the way down. If you look at medical costs, you'll see $11,359 versus $12,142. This is yearly costs, a difference of $783. That little C points to this being statistically significant. And while they were at it, there were other clinical, by the way, it's not just about costs, but there were clinical outcomes that were also driven as a result of TRICARE's investment in disease management program. And all these 3 studies, by the way, that I'm quoting, have just appeared within the last 1 to 2 years. So I'll pose now for a polling question. What additional features do you feel is necessary for successful case or care management? Keep in mind that this is a pre-polling question because I'll have some pointers on this as my presentation goes on. So we'll wait a minute and give everyone a chance to vote. And by the way, I'm not allowed to vote, darn it all. Interesting. So a lot of people really feel that that it's important for who's ever doing the care management, the case manager, to be employed by the primary care site. We will be addressing that. So assuming pretty soon I can get control. All right, looks like I'm back. All right, good. So what are the ingredients? And is one of those ingredients a case manager, care manager, and what should the status of that care manager be? Well, let me go through this real quick. Now this is the world according to Sidorov somewhat, but when I read the literature about what works in population health management, and I think about what can be exported into the patient-centered medical home, this is what has come up. The first is the notion of risk stratification. Every population has patients that are of greater need than others, patients who are greater risk in the future for hospitalization or for a complication or for an emergency room visit. I think everyone here listening on this phone call recognizes that. It's well known that among a population of hypertensives, for example, that there are low numbers of patients that have extreme hypertension, and most patients have quote-unquote moderate hypertension. And if you look at the distribution, it only makes sense that the patients with the highest blood pressure are the ones that should be pursued most avidly. So, for example, if I had a group of patients with hypertension in my patient-centered medical home, I'd be more interested in going after the patients with blood pressures in the systolic range of 196, even though they're few in number, because they are the ones with the greatest risk in terms of cardiovascular endpoints. That's the purpose of this particular graphic that I took out of JAMA. So park that in the back of your mind. Risk is not evenly distributed, and there are patients that are at greater risk than others. The second ingredient to think about is patient enrollment. In the population health management space and in the patient-centered medical home, if patients are pursued by case managers or by their primary care provider with letters or phone calls saying, hey, we have a diabetes program or we have a hypertension program and we'd like you to enroll, it's not unusual at all for enrollment rates to run in the range of 5 to 15%. Now there are good data that indicate that if you get the primary care physicians engaged in personal outreach, that enrollment can increase, but still that takes a lot of work, and if you automate it in typical settings, the enrollment may be as low as 5% or 15% depending on how you're doing. Now you can increase it with patient incentives and the like, but that's usually more suitable for a work site. Think of it this way: in the span of patient risk, and if you look at the number of enrollees on the y-axis and the costs and charges per member on the x-axis, this is how the distribution almost always works out for a large population. There are some patients who have who number very low. They have very low charges and costs per member. Most of us, see the doctor once or twice a year. We have moderately low costs, and then there are patients who have unbelievably high costs. They're low. They're likewise low in number, but as everyone knows, in the 80-20 rule, they account for most of the cost. I would suggest that the patients with very, very high costs, patients, for example, who have end-stage disease but are not necessarily suitable for hospice, for example, that their cost trajectory is somewhat fixated. It's very difficult to moderate that cost. That doesn't mean that there isn't a lot to be done clinically, but from a cost perspective, there isn't much that you can modify there. There are patients in the middle, though, the sweet middle that I term, who are chronic care, medium cost, and have manageable risk. And I would suggest that when it comes to achieving a quote-unquote return on investment, these are the patients who have moderate risk in that risk spectrum, who, if you do engage, can have a benefit in terms of moderating their risk. So this is an argument that says that 5 to 15% enrollment isn't necessarily a bad thing if you're just looking at this from the point of view of trying to achieve savings in a population at risk. And this is how it turns out from the point of view of return on investment. As you increase enrollment, when you first start out, you have a very, very negative return on investment because you have to hire a lot of nurses or non-physician professionals. You have a lot of upfront costs. As you begin to pursue the patients at highest risk and you moderate their cost trajectory, you get a very, very quick return on investment. But as you continue to go down the line and pursue patients with lower and lower levels of risk, even though it may make clinical sense to do that from a pure return on investment point of view, the return on investment can go negative because you're not necessarily moderating the risk because you're moving your activity to the left of this curve. So this is just something to keep in mind when you're thinking about trying to achieve a return on investment or achieve savings in a shared risk kind of arrangement. Number 3, something to think about is multiple communication channels. We all grew up with one-on-one education, handing patients booklets. If you go to the National Heart, Lung, and Blood Institute and look at the patient education materials, there's a lot there that can be printed out, but it turns out that there is a lot of education that is bidirectional. Texting, Facebook, Twitter, and the like. It still remains very much to be seen how this works out, but it's still something very, very much to be considered and also being used, I think, in a novel way by some primary care sites. It's just that we haven't really seen much of that in the peer-reviewed literature. And last but not least, nurses, your ship has come in. Finally, they're going to get the recognition that they deserve, I think, under this new system of accountability, because they are the ones who can really pull together the risk modeling, facilitating patient enrollment. They can advocate on behalf of the intelligent adoption of clinical-based guidelines, and they can collaborate and integrate with providers. If you pair me with a good nurse care manager, I can really manage a population. Now, what are the features of a successful care manager? I've listed them here. This is a picture taken involving a nurse from overseas, but I thought it was the best picture of the kind of person that we would want as a care manager. Someone who's mobile, someone who interacts with patients more than once a month, someone who's working at the top of their license and, yes, can somewhat autonomously use protocols to moderate prescription medication use among patients. They need to be connected into an electronic health record. They need to be dedicated. This is a full-time job. This isn't something that a discharge manager from a hospital can do. These are full-time professionals whose job it is to take care of patients and manage their risk. There are credentialing programs out there. The outreach to patients is both telephonic and face-to-face. As I indicated before, there's some data that indicates that telephonic management can achieve a positive return on investment. Their job is to help patients take better care of themselves, and in many instances, I will argue that these professionals can act as change agents. When they're placed into a primary care site, they really can change the culture. I've seen it happen. Now, let's address some real quick hits. The first is the research. What kind of proof do we need as skeptics, as eternal skeptics, that this care management, that this patient-centered medical home really does work, that it drives value, that it increases clinical outcomes, and it reduces healthcare costs? I've been, as someone who's published in this area, I've generally found that in-house, when you're doing your own studies to try to figure out whether or not you're actually doing any good, you have a choice of 2 out of 3. You can achieve speed, you can achieve accuracy, or you can achieve completeness, but you're never going to be able to have all 3 to be able to convince skeptics in the audience, short of a randomized controlled clinical trial, that the outcomes that you're achieving actually work. And the best that we're going to be able to do is make sure that all the studies are pointing in the same direction. The second thing I'd like to point out is that when it comes to care management programs, especially in a primary care network, this is not a souffle. With souffles, you have to cook everything exactly right, or you're going to have a lousy souffle. The oven temperature has to be precise. The ingredients have to be mixed the same way all the time, every time. I believe that care management in a primary care setting is very much of a soup. Primary care sites and their patients have quite varying cultures. What works in a coal town in Pennsylvania isn't going to necessarily work in an Hispanic community in Los Angeles, or in a college town located down in the South. And it's okay to be somewhat adaptable and to moderate things well. There's the concept of central administration versus peripheral distribution. If you look at this particular study from Massachusetts General Hospital, the care managers were hired centrally by Mass General and distributed out into the primary care network. So these nurses were not hired by the primary care site. These nurses were allied with and looked like they were members of the primary care site, and they worked very well with their primary care providers, but this was not a cost borne by the primary care site. And I would argue that that it's not necessarily true that the nurse-based team member, care manager, necessarily has to be an employee of the primary care site, which brings up an interesting option, the shared services model option, where you have a centrally coordinated program that hires the care professionals and launches them out into the primary care sites. This is something you want to do when you have a short time window. If you're looking for competencies, if you want to unburden the physicians, and it can work very well to complement and further the medical home. That's why it can be argued that it may not really matter who actually, quote, hires or quote unquote the nurses, because many times in just something to think about, if there's a partnership between a commercial insurer and an accountable care organization, which is what we're seeing, why should it matter where that cost actually resides, just so long as the nurses are face-to-face with the doctors and working with them shoulder to shoulder in the trenches of primary care? Just something to think about. This is a picture of a chief financial officer or a practice manager being told that my read of the literature is that if you're going to hire a nurse or a non-physician professional to do care management, the ratio of nurse to patients is 1 to 1,500. So for every 1,500 patients in an at-risk population, or assigned to a clinic or in an accountable care organization, that's one nurse. That seems to be the industry standard. You'll see some slides later on saying that the number may be even lower, so the top end of that is 1 to 1,500. Now, an average primary care physician takes care of about 1,500 to 2,000 patients, so every PCP out there is going to need one nurse to do this, to do that right. How about the docs? There are many arguments that can be made to the physicians when you're trying to get buy-in for the patient-centered medical home, and I've listed them there. I will tell you that personally, as someone who's gone before physicians, that I found the last two bullet points resonate the most. Physicians, I can give you money, I can give you patience, or I can give you time. It doesn't look like under the current setting, economic setting that we're facing, it doesn't look like there's going to be a whole lot more money coming into the healthcare system. I can give you more patients, but primary care providers already have plenty of them. What care coordination does, what population health management does, its real purpose is to save the physician's time so that many of the routine tasks of care can be offloaded. When you talk to doctors about saving time, they like that. Last but not least, they also seem, in my experience, to like the argument that they can do physician stuff. I will be the first to tell you that in my medical training, I was never taught how to engage patients and review barriers and develop a care plan. I really do feel that my job is to pull the coals out of a fire when a patient is doing really poorly. With time and with good care coordination, the incidence of complications should go down, but they'll never go away. The purpose of the doctor is to see patients who are in trouble and take care of them when they're sick, and good care coordination programs help them do that. So here's another polling question. What additional ingredients are necessary to aid physician engagement? Is what I said enough? Or are there other things? Like, for example, should local physicians be charged? Should you include, should you, this is somewhat shortened, but if doctors don't participate in care management programs, should their credentialing be put at risk? And then last but not least, and this is kind of a joke, but I thought I'd put it in anyway, you can insist that they view a rebroadcast of this presentation. So please don't answer that one. Good. So there is a role for physician leaders. They're often, I've heard them called key opinion leaders, and some folks seem to believe that doctors, it's really important that you do this, and it may be something that we should link to your continued participation in our system, or we should look at it as an item in the course of credentialing. Interesting. And I'll close with this, what's at stake here. I really believe that that the public option is still very much an important consideration in Washington, D.C. We know all the travails that the Accountable Care Act is going through. It's currently before the Supreme Court. But this the patient-centered medical home, and leveraging it to achieve greater accountability and savings, and reconciling both increased clinical quality and lower healthcare costs is very, very important. And if we don't do this well, we're going to see increasing calls for increased government involvement in healthcare. Many may not feel that's necessarily a bad thing, but this is really the last chance for the current system to be rearranged to make this really work, really work well. So I'll thank everybody, and it looks like I got done pretty much on time. So thank you very much.
Thank you, Dr. Sideroff. That was fantastic. At this point, we'll hold questions until the very end of the presentation, and we'll transition to Dr. Crawford.
So yes, thank you. And my title slide speaks to what I think the role of the second speaker in this webinar is, which is, so how are we actually supposed to do this? And let me give you a little bit of background here. The satellite image there is the geographic coverage area for the North Shore Long Island Jewish Health System, with about 15 hospitals, 200 ambulatory practice sites, providing annual care to about 1.6 million unique patients per year, 38,000 of whom receive their care through a patient-centered medical home. And laboratory data and access to laboratory services is one of the big problems, and it really led me to not only get centrally involved in the building of both accountable care and the patient medical home in this health system, but also to turn to the Patient-Centered Primary Care Collaborative in the fall of 2008 to really be part of that national movement. So the perspectives that I'm bringing here are from the, if you will, the trenches of implementing both coordinated care and patient-centered medical home in our own health system, and then whatever I could pick up along the way at the national level. And in the simplest sense, and this could come straight from the 2010 legislation, quote unquote, savings and improved health care are to be achieved through coordinated care. This is in the federal statute. So it's nice to turn to the published literature and see what people consider coordinated care. And I think it's very reassuring to identify things which I think every physician, particularly primary care physicians, will be cognizant of: chronic disease management. A very important aspect right now is management of ambulatory sensitive conditions, which are those conditions that, if well managed, can help patients stay out of the hospital and avoid going to the emergency department. And the big four are heart failure, chronic obstructive pulmonary disease, diabetes, and coronary artery disease, but there are many others. Management of transitions care, what I would call up, down, and over being referral to a specialist or ancillary services. Medication reconciliation and reduction in errors. Those three, transitions and the medication reconciliation that goes with it, are one of the major sources of both error and patient non-compliance. Screening and follow-through, and then the actual process of receiving emergency care and follow-through on that. The literature on coordinated care is very robust, and I always like, when I do a lookup in PubMed, I always like clicking on the origin of the term, and you can learn some interesting things. In this case, the concept of coordinated care and these various monikers has been around for a long time, and as of January of 2012, there were almost 48,000 publications. If we plot this out on an annual basis, though, you can see that not only has there been increasing interest, but the last year, after both legislation and really a substantial change in the marketplace, clearly this is a topic of the current times. To me, a major contribution of the healthcare reform effort, with or without input from the Supreme Court, is the fact that the relationship of patient-centered medical homes to an encompassing healthcare organization, whether it's accountable care, integrated healthcare, whatever you want to call it, the two really fit together, particularly if there are multiple practices providing coverage for a population area, all of which wraps up into an integrated healthcare network. And it's really from this perspective that I'll be speaking. In my own conceptualization, and this is something that I was observing in my early year or two with a patient-centered primary care collaborative, the medical home is focused on patient care through a physician practice. And it bothered me that the missing piece was the wraparound, the medical neighborhood being one term. An accountable care organization is centered on the concept of providing coordinated care at a health system level. And the trick is to put these two together. I think they fit together very nicely with or without an integrated corporation. And if we go back to the literature and use the simple search term accountable care, you can see again, although the number of publications is 20-fold less per year, again, this is an idea which is rapidly taking off, and I think we will be seeing much more coming forward both in terms of editorial opinions, but as Dr. Sidoroff has pointed out, actual information from the field as to how effective these approaches to healthcare are. But if our health system is any reflection, the relationship of patient-centered medical homes to a health system is much more complex than just a simple pie chart, because there is escalation of care from the medical practice or in spite of the medical practice through emergency departments, hospital admissions, discharge, either back to home, into rehabilitation facilities or what have you, or back to nursing homes. There are patient transitions from the patient-centered medical home to any manner of specialists, and it can be very difficult to track those transitions. And then there's the whole industry of ancillaries, including pharmacy, laboratory, and imaging. And as I try to conceptualize this, we could go back to that rather frightening slide from Dr. Sidoroff. I was glad that he simplified it down. And I'm not going to try to tackle this either, but as I look at our own primary care practices, try to deal with this, there are two perspectives. The first is, I think, to draw upon information in the Congressional Budget Office publication from January of this year, which is lessons from these Medicare demonstration projects. And the first is that there's a difference between disease management and care coordination. Disease management is, according to this report, patient education, motivational programs, and note that this is to promote behavioral change. Monitoring, you can see lots of monitoring of patient symptoms and metrics. Note that biometrics in a laboratory play a big role there. Patient adherence to treatment recommendations, providers' adherence to evidence-based practices, and then providing feedback to patients' primary care physicians. That last part of the loop can actually be rather hard to close if the disease management program is not already integrated into the practice. And this gets back to Dr. Sidoroff's first question, is there integration of care management? Same can be true said for disease management. If it's a distinct and unrelated telephonic program, for example, I have not seen that be anywhere near as effective. Disease management programs are typically focused on a specific chronic disease. We compare this with care coordination. The first criterion of care coordination is the management of information flow between providers, and that can include within the primary care practice, between the mid-level providers and the physician, between practice sites, and then ancillaries and into and out of inpatient facilities. But just the management of information alone is an important part of standing up care coordination. Proactively managing transitions of care, knowing when your patients are going into the hospital, knowing when they're coming out, and that takes effort to figure out when they're making transitions in care, helping patients access medical services and social support services. And a final point is that care coordination has to take into account patients' multiple chronic conditions. If we compare disease management, they tend to be focused on chronic disease. Disease management for diabetes, chronic obstructive pulmonary disease, and heart failure is hard to do if you only have this lens. You have to have the lens of care coordination as well. And in order to accomplish the care coordination, and this is drawing directly from the publication that Guy Mansueto mentioned initially, the core value community connections, you need these following things. On a per patient basis, the practice needs to have data interoperability, which means hopefully you have a functional ambulatory electronic health record. If you're lucky, it is interfaced or synonymous with the inpatient electronic health records so that you can see what's going on in the hospital, and when you're in the hospital rounding on your admitted patient, you can see the records from your practice. You can see laboratory information. Ideally, you can bring claims back to your practice so that you have a sense of the cost of delivering care. Right now, I put it in current because that is a required current data element. It's actually very hard to do in the current climate. And then lastly, you need to be able to track the medications of your patient. In the future, ideally, emergency department information systems will be linked in, You will be able to go into the imaging information systems so that you can actually see the studies that your patients have had, and you will be able to interact with the pharmacy information systems so that, again, you can proactively manage this. Just the current is enough to make progress in care coordination. Data completeness. I like Dr. Sideroff's triangle because accuracy and speed was, to me, where I would vote. Completeness is very hard, and the biggest problem that I'm seeing in our own health system is the flow of information to and from specialists. It depends on how engaged specialty practices are in communicating to you. If they are using electronic health record, the easiest thing to do is just scan documents and then you have to dig them out. For the different physician practices to be totally useful, ideally they and you would be using a common electronic health record with parsed data. Data access, this is a fundamental concept. For you as a provider, having the information you need to make management decisions at the point of care is the ideal. Very hard to achieve. And then the last point is critical. Execution of a care plan. Dr. Sideroff mentioned the construction of a care plan for any one patient, particularly those with multiple morbidities. It is the care plan that will allow you, hopefully, to provide better managed care for them and achieve better outcomes, including staying away from the emergency room. That requires that multiple providers be able to have access to that care plan, and I would submit, if those providers are making their own decisions, for example, a specialist, that they have input into how that care plan is modified. The second point also must be taken into account. It isn't enough just to know what you want to do. You have to know when you are going to do it and what might be called a critical pathway. What is the chronological order of executing a care plan? And that could include what physicians does an individual see when, what social service support do they need, can they get to the pharmacy on a timely basis following a discharge from hospital. Very simple things in the order of life that if the care plan and you as a managing physician don't take into account, your lovely care plan will fall apart because you're not executing things in a logical order. The data elements required for managing a population have already, Dr. Sideroff has already foreshadowed these. I see it as your ability to segment the population, but there are various ways to segment it. The first is by disease condition. How are your diabetics doing? How are your patients who struggle with heart failure? What is their readmit to hospital rate? Looking at your practice's ability to achieve favorable outcomes for patients with any particular disease condition. That's one segment. The second, which I think is a very pragmatic one, is what coverage arrangements do your patients have? Is it a Medicare contract? For example, those who are involved with the Pioneer ACO pilots. What I'm seeing is that we're entering into a time now where different managed care contracts will dictate, in essence, how the patients are engaging with the healthcare system, and the physician being aware of what's in system for the patient, what co-pays they have, the various constraints on their interaction with the health system will be helpful. I think from managing a population, from the perspective of a physician practice, being able to understand what your portfolio of care plans are. Again, what do your patients need and when, and is your practice being effective in helping your patients meet these needs? Population reporting is where the accountability comes in. Patient registries is a fundamental aspect of having a highly functional electronic health record. In the simplest sense, you could say an electronic health record is a workflow manager, and being able to roll up your data into a registry is not required to turn the system on. But until you can have a registry and actually see how your patients are doing, I think it's enormously frustrating at the level of the practice. So to the extent that your electronic health record can get you started in assembling your registries and then building the metrics for those populations, not only will you have a much more satisfying interaction with your electronic health record, but you will actually be able to see how you are doing. which leads to the third concept of the data elements, and that is that the best data is your own. You can read the literature, you can, particularly if you're part of a large healthcare system, all kinds of evidence-based guidelines will come down to you. But in the end, and the Institute of Medicine has advanced this concept, the best data is the data from your own practice and your own health system, which means you need to be able to monitor your practice patterns and outcomes. And in having that kind of feedback, you can modify your practice, improve operations, adjust your adherence to guidelines. You can innovate, again, at the level of the practice, and hopefully improve your ability to achieve the outcomes you want. I think I have to click back. Okay, so the impression I get, though, as I look at our own primary care physicians try to deal with this, it's an awful lot to ask. Try to throw a lasso around all these different data sources from the perspective of a physician practice is very difficult. And this is where the concept of care coordination, I think, really comes to the rescue. I could ask, who really does this stuff? You could look at sort of strata similar to what Dr. Sidoroff said. Low-intensity disease management, for example, a patient whose creatinine is just beginning to move out of the normal range. Medium intensity, the middle curve, part of that hypertensive curve that Dr. Sidoroff showed, or high intensity, who are the patients who are in and out of hospitals with multiple readmissions owing to multiple morbidities. The challenge that I see looking at the discussions that go on with the Patient-Centered Primary Care Collaborative is challenges to an isolated patient-centered medical home that is not necessarily part of an integrated healthcare system, and a physician versus a physician practice that's part of an integrated healthcare system. So what I'd like to do right now is ask you to respond to the polling question, is your physician practice part of an integrated healthcare network? And the answer is a little over half are part of an integrated healthcare network, but a substantial minority are isolated practices. And I'll be trying to provide perspective for both settings. So if we get back to my controls. The way I'm seeing it, in the isolated patient-centered medical home, and we'll ignore the asterisk, incorporation of care coordinators, where nurse care managers are sort of the paradigmatic opportunity, but there are other elements to care coordination, including telephonic support, can be placed into an isolated patient-centered medical home. And I should note, based on work that we've done with a major employer, that health plans provide telephonic and web-based support frequently. And one of the questions that I won't try to answer here is whether these independent telephonic and web-based support systems are helpful or sort of non-contributors to the ability of patients and physicians to manage disease conditions. If we look at the patient-centered medical home as part of an integrated healthcare system, either in a centralized fashion or in a sort of centralized with regional deployment fashion, case coordinators can come into play. And I'm differentiating a case coordinator from a care coordinator. A case coordinator is one patient entering into an episode of care, typical example being entering into care for cancer, is navigated through the health system, as opposed to a care coordinator who will be managing a population of individuals through the practice setting. So nurse care managers can be part of an integrated health system. Home care specialists, individuals who will round on patients at home, particularly post-discharge, but also as part of longer-term care. That may also include rounding in skilled nursing facilities, and again, the possibility that health plans are providing telephonic and web-based services. Both of these things can occur. Both of them, I think, can be beneficial, and I think the data would suggest that. At the health system level, when these activities are rolled up into a fully integrated operation, we could call it a care maintenance organization, which is not just nurse coordinators and nurse care managers. The organization has to include actuaries, which is part of this predictive modeling that Dr. Sidoroff mentioned, and information technology specialists. And if I were to draw from our colleagues across the Throgsneck Bridge and the Montefiore system, the balance between the nurse care managers and everybody else, the actuaries and the information technology specialists, is about 50-50. So the second polling question is, if you have care managers within your practice, how many patients are in their panel? This gets at what Dr. Sidoroff was mentioning before. First question, of course, is, do you have any care managers? So we don't have a not applicable here. So I guess if you don't have a care manager, you won't be able to answer this question. So actually, half of our respondents have care managers that have a panel of more than 500 patients, and it does go down to as low as 100 patients. So a distribution, but definitely pitched towards the higher side. Okay, so let's return to the talk. Going back to both my own experience in the North Shore LJ Health System, as well as the Congressional Budget Report, what I would call gaps for the isolated patient-centered medical home fall into the following categories. In the realm of health information technology, does your electronic health record actually work? And sort of lurking in the background here is the concept of meaningful use. Does your electronic health record allow you to identify your patient registries, have alerts for patients who either have data that's out of whack, again, laboratory data, or are not filling their medications, or are not getting the lab testing done when they're supposed to? Do you have the data analytics? In order to particularly do the alerts and the data analytics, you need to have good data interoperability. You need to be able to get data back from your labs, from the referrals to other physician practices, from transitions in care into and out of hospital, and yes, be able to track their medications. Second, can your patients be tracked? And this brings us to the concept of health information exchanges, because ironically enough, in our own health system, we have a very good health information exchange in our region. And sometimes for a physician, it's easier to go into the health information exchange to get data from our own health system than it is to have interoperability from our own practice sites. And so, yes, health information exchanges can be very helpful. The question is, how complete are they? Can you actually find out what's happening to your patients? In regards to personnel, a recurrent theme is that on the one hand, you have the issues of your own practice transformation, but on the other, if you're an isolated patient-centered medical home and you're trying to find out what's going on with your patients elsewhere, you are dependent on other people, the specialists and ancillaries, to both be compliant with the protocols for care coordination, and I dare say collegial in so doing. All of this then takes us to the fact that in a busy primary care practice, there's a very narrow margin for the inefficiencies of transforming your practice to be able to do care coordination and to stand up these activities. Gaps at the level of an integrated health system, and we're seeing them all, is whether there is alignment, whether there is reason, incentives to do coordinated care, or whether it's better to sort of stay with the current system of fee-for-service as opposed to risk-sharing. It's a tough transition at a health system level to move into care coordination. Health information technology, the functionality of the electronic health records in and of themselves, and the data interoperability. And I'm also seeing, and I'm sorry to say it, the fact that within the grand schemes of system health information technology priorities, individual patient-centered medical home practices may be fairly low priority, and fixing the problems with EHR may be hard to prioritize. Is a care maintenance organization structure present or not, and what is the model for integrating with patient-centered medical home practices? These are all gaps. They are potential barriers. I don't believe in a perfect world. I think that either as an isolated patient-centered medical home practice or as one as part of an integrated health system, you can make progress, but it is slow. The Medicare demonstrations, again, the Congressional Business Office report from January of 2012 points out where gaps have occurred, and this actually is a strong echo of what Dr. Sidoroff has said. When care managers are not integrated with physician practices, that's one area where results have not been forthcoming. And it's not a matter of employment, it's a matter of functionality. Telephonic programs that stand apart from physician practices, inability of practitioners to obtain data from hospital admissions. And the CBO noted that Medicare does not require pre-authorization when a patient is admitted to hospital, so that no one necessarily knows that the patient has been admitted to hospital. And lastly, whether the care maintenance structure is in place and integrated with patient-centered medical home practices. Where there have been successes is when care managers are an integral part of the physician practice, where telephonic programs are integrated with in-person contact, and that goes right back to Dr. Sidoroff's comment about nurses who see patients and also are in telephonic contact with them. Proactive and monitoring and supportive care transitions. Very importantly, education and support of physician adherence to guideline-based care. And lastly, pilot programs that used home telemonitoring and video conferencing also had favorable outcomes. So in the end, quote unquote, on average, the 34 disease management and care coordination programs had little or no effect on hospital admissions or regular Medicare expenditures, including the fact that when fees were at risk in a demonstration, there was no effect. But when care managers were integrated with physician activities, this is where reduction in hospital admissions of up to 7% were observed, and a reduction in regular Medicare expenditures. Independent or telephonic-only care managers had no effect on hospital admissions or expenditures. So to start bringing this home, what I would say is that if you're going to go after low-hanging fruit to try to achieve care coordination, the registry, the disease area that can yield favorable outcomes are first ambulatory sensitive hospital admissions, and diabetes, heart failure, and chronic obstructive pulmonary disease are where the most opportunity is from the data. This is sort of management of single conditions, but these tend to be comorbidity patients, and it is the care coordination that can help achieve these favorable outcomes. Transitions in care, the more you can anticipate proactively a patient discharged from hospital, for example, the better, the more likely the outcome. And then patient engagement, which is not something for this talk today, but patient education and motivation. And the literature would point out the fact that when patients have access to their own information, it is most motivating. Sort of generic educational materials that are not populated with their own data is not as effective in motivating patients to change behavior and be compliant as information which includes their own personal data. The big challenges, particularly when you start managing populations, or at least conceptualizing management of a population, is that patients may have poor social support systems. There may be substantial barriers in access to health care, just mobility out of their own home being a key one. From the physician standpoint, can be difficult to adapt so-called best practice guidelines on a disease-by-disease basis to complex patients with multiple comorbidities. And lastly, we ignore behavioral and mental health issues at our own peril. There is a substantial percentage of patients with chronic diseases who are also dealing with depression. And so ultimately, whether you're an isolated practice or a part of an integrated health system, the ability to deal with mental health is going to significantly influence outcomes. To move into this kind of world as a practice requires a number of changes, and this, I believe, will also be part of a subsequent webinar. Transition from physicians who are separate from the coordinated care team to one in which physicians are integrated with the coordinated care team. Physician leadership that's resistant to change, physician leadership as a champion of change, and then some rather interesting pieces of information coming out of the publications given below. Selection of an electronic health record without understanding the fact that there will be substantial changes in the role of particularly mid-level personnel, but also the physicians themselves can impede these transitions. Failure to identify practice core values, namely, what is your practice currently doing with regards to care delivery guidelines, and what are your successes currently? What are your existing preventive services? So the ability to retain what you are already doing well as you move into a new care coordination model. I think it's fair to say that when one transitions to a patient-centered medical home, on a new electronic health record, stands-up care coordination, persisting through transitional inefficiencies takes a lot of fortitude, but is required. And then lastly, alluding to Dr. Sideroff's side about what do physicians really want to do, stepping away from the practice setting to reflect on the change in practice and to build relationships with all of your office personnel during the change is necessary to achieve success. The CBO says this is not forced time. It is actually an important and necessary part of identifying how to provide excellent care under a new model. And so, in conclusion, whether you are an independent patient-centered medical home or a medical home that's part of an integrated health system, integrating care managers and physicians is important. The electronic health record needs to be selected and implemented clearly with changing roles and workflow redesign in mind. You need to be good change managers, and I would emphasize in an imperfect world, step by step, the build of obtaining data through the care transitions of patient care, systematic management of a population, and tackling the low-hanging fruit while keeping in mind big challenges and trying to make inroads on the big challenges will ultimately help us get to where we need to go for better care coordination. I'd like to leave you with one final thought. I have made the effort to change my vocabulary from patients to people. Population health is dealing about people, is caring for people, not patients. And I think it was said best by René Debow, who was one of the 20th century's preeminent microbiologists and was a cardiac cripple, having had severe rheumatic heart disease at age 9. In his 1959 book, The Mirage of Health, he states, health is not being free of infirmity. Health is doing what you can in spite of your infirmities. And I think our caring for populations and helping them do what they want to do is really what we're about, and care management is one of the key elements. So thank you very much, and I believe we have time now for questions and answers.
Great. Thank you, Dr. Crawford. It was very, very informational. At this time, we will begin to take questions using the GoToWebinar controls. We already have received many questions. We have about 15 minutes or so to take questions. Anything that we don't get to, we'll do our best to respond after the webinar. The first question is, in the simplest sense, what are the critical initial priorities for assembling care coordination at an individual practice level?
So I'll take this. One way to think of this is if you're going to make one hire, what hire would you make? And I would submit that the nurse care coordinator is an outstanding initial hire. You have to start somewhere. You need to be able to step away from the 12 minutes per patient pressure, and in essence be able to say, okay, how are we going to manage patients through their various transitions in care? How are we going to ensure that they're compliant with our recommendations? So I think that's a top priority.
I agree.
Functionality of the EHR and your ability to identify your patients in a registry is I would say, the first data information priority. My observation is you're not always in control of that, and if you don't have full registry function, you can still begin building care coordination, but it will be more difficult.
Okay. Next question has to do with the stratification components. Remember that addressing those in the lowest risk category decreases the demand in the high cost and high risk categories. Everyone receives case management appropriately for acuity. How best can that be applied within a care coordination setting? How best is the risk stratification applied to focus on the patients with the highest needs?
I'll take that. There's an obscure statistical phenomenon called regression to the mean. Many persons on this phone call will recognize that. If you go to Wikipedia, interestingly enough, there's a good discussion of that. But it basically points out that today's high-cost individuals are not necessarily going to be tomorrow's high-cost individuals. And if you address your care management attention on those persons who are high-cost today, you are almost guaranteed to see a gratifying decrease in their healthcare costs. It's just that you won't know if it's because of your care management or if it's just because of the statistical phenomenon of regression to the mean. Those patients were destined to get better anyway. The purpose behind risk stratification is in that pool, in that larger pool of low-risk individuals that you have in 2012, who among them are going to be high cost in 2013? It turns out that there are some statistical, regression-based, analytic tools out there that can identify those patients that are destined to be high cost. So among the low-risk group, those persons who are destined to be high risk, that is where the money lies. That is where the greatest need is. Those are the individuals that are greatest risk. Those are the individuals that are going to be going to the emergency room and being hospitalized over and over again. And for the clinicians in the room, the doctors, the nurses, and other folks, intuitively, I think everyone would understand that. You know, the feeling that you get when you're dealing with a patient who is struggling, doesn't quite get it, is doing okay now, that you're not surprised 6 months later when you find out that they've been in the emergency room, and between now and then there wasn't really much that you can do. Well, it turns out there is a whole lot you can do. You can do exactly what Dr. Crawford said. Hire the case manager. You have your registry. Number 3 is apply those statistical analytic tools and then aim your care management resources at those particular patients. Not to say that patients at lower risk don't also deserve care coordination, but I would submit, just as Dr. Crawford said, there's high intensity, low intensity, and medium intensity and low intensity, but the lower and medium intensity is better suited for patients at low risk. You want to go after the patients at greatest risk for 2013, not based on 2012.
Great, thank you very much. There was a number of opportunities or elements within the presentations that talk about care coordinators or care managers or nurse care managers or even case managers. How are each one of those roles really defined in a medical home environment? Is there a difference, and what would that difference be?
Both of us might take a stab at that. Speaking from the perspective of a health system, let's start with case manager. When a patient is entering into an episode of high acuity care, a case manager can help that patient navigate through the system. Even just getting to the right place can be enormously assisted by a case manager. That case manager arguably is completely separate from the patient-centered medical home. Basically, the patient has been handed off to the big system in all its confusion, and you're just trying to get the patient through the system. For a case manager and all the physician providers who interact with the patient, the key is the hand back. It's the transition back to the medical home, starting with medication reconciliation, but very importantly involving follow-up after discharge, verifying that the patient understands what the instructions are, both for behavior as well as pharma, and perhaps most importantly, making sure the physician at the other end knows, that the primary care physician knows what has happened. So that would be a case manager. A care manager from the medical home perspective is someone who is, through the ambulatory life of a patient, is trying to make sure that the right things are happening and that the patient hopefully is compliant with the care plan. And the ideal world would be for even patients with rather severe comorbidities, successful management under a care coordination model will keep them out of the emergency room, will keep them out of the hospital, or at least will reduce their need for high acuity care. I can't remember the third definition that you were asking for, but why don't we let Dr. Sidoroff also respond?
Yeah, I mean, I agree entirely. This is an example, I think, of maybe the soup of what we're talking about, and what Dr. Crawford outlined is certainly the mainstream thinking that there's a difference between case manager, which is more one-on-one, higher intensity for patients with more catastrophic illness, versus care management, which is more primary care based. I've heard other titles and other terms attached to that, but basically when a patient population is risk stratified, there are the patients at greatest risk, medium risk, and lower risk. It's almost like triaging, try being 3 levels of care. So for the persons at greatest risk, those are the patients that probably require more intense case management. Then there are patients at more moderate risk. Those are patients that are still very closely allied with their primary care provider. You can call that care coordination or care management. And then at far lower risk, those may be the patients that would benefit from telephonic management, coaching, and I've heard other terms out there used, care coordinators, patient health coaches, and the like. But you get it, and the actual title is less important than the concept and being able to target the appropriate resources at the right level of risk.
There are 2 other comments I'd like to make. You saw the term on Dr. Sidoroff's part of the talk, invisible patient. And that's a critical element of managing a population, is identifying the patients who aren't moving through their care plan. They may show up in an emergency department abruptly because something is going wrong. Care management and your care coordinator is supposed to catch those people and make sure, either telephonically or more directly, that they're adhering to their care plan. The second is, if we think about a patient going to an emergency department, the term that I've sort of grown up with is treat and release. And it gives me the image of, a patient coming in and just sort of being, released back into the sea like a fish. That's not what care coordination is. If a patient does need to receive care from an urgent care center or an emergency department, they should then be returned to a coordinated care environment. Hopefully the medical home physician is aware of that event. One way or the other, there has to be a handoff so that the follow-up after the emergency department event is smooth. And I'm speaking about chronic conditions. If you need stitches in your hand, that's not what I'm speaking. I'm speaking about someone who's going in because they're short of breath and they have chronic obstructive pulmonary disease or what have you.
Okay, thank you very much. There's another question. I think we saw within the poll that there was a wide variety of different patient panel workloads assigned to care managers within a medical home. I suspect most of that has to do with the variability of the services offered and how the risk stratification occurs. But is there an ideal panel size or number of patients that a care manager should be able to manage? And can you talk a little more about that?
Dr. Sidoroff?
Yeah, I'll take a stab at that. The 1 to 1,500 is the total is one manager for the number of enrolled patients in a population. So if an ACO is taking care of 15,000 patients, you can do the math on how many nurses or other types of care management health professionals need to be employed. As far as the individual portfolio that each nurse has, I'm going to speak off the cuff, and my colleagues who are case management trained may have better resources better ideas about this. But the higher the level of acuity, the lower the nurse to patient ratio. So a typical case manager doing hands-on care for patients that are really, really high risk. I've seen an average caseload of 30 patients, 40 patients. When you're doing quote-unquote disease management or care management, that ratio can go up 50, 60, 70, as high as maybe 100 patients at any one particular time. I'll also point out that it's not that while one element of success is not only the nurse to patient ratio, it's also turnover. So it's one thing to have a good nurse, case manager taking care of, say, 50 patients, but it's even better when there's 10 patients coming in and 10 patients going out every month, so that the nurse over the course of the year is touching as many patients as possible.
And actually, that's to follow on. That's a key concept of the case management part of the equation, because the case management is during escalation and care. And so for a given population of patients, it's only going to be a small subset that needs the intensive case management. But in the process of doing that, number one, their episode of care hopefully will be more successful, especially their repatriation to the ambulatory setting. But the second is the numbers actually work out. Your case manager will wind up touching a very substantial number of patients over the course of the year. One of the discussions that I've run across is the fact that the sort of traditional concept of a nurse practitioner as a physician extender doesn't actually change the model of care. It is still, I am a healthcare provider providing for my patients. A nurse care manager or a care coordinator is caring for a population. It's actually sort of passing your hand over the waters in a much broader sense, so you can identify the patients who are in need on the basis of their care plans, either proactively to make sure that they adhere successfully or proactively to identify where they're falling out of compliance. So it changes the frame of reference for the patient interaction from a singular episode, evaluation and management, E&M code-based operation as a physician extender to a population manager.
Great, thank you very much. Next question has to do with risk stratification. There are a number of questions related to this topic on what the best risk stratification tool that works best for patients in a medical home, and where can those tools be found. Is there any insight that can be offered on that?
Yes. Most of the risk stratification tools out there, interestingly enough, are for sale by organizations that have very, very, very good tools, and I will not mention them over the line because I don't want to appear as if I'm recommending any one organization's risk stratification tool over another. But they are out there, and if you do a web search, and in particular, if you do a web search on predictive modeling, there's an excellent PDF out there on a purchasing guide for Medicaid programs. It's a good discussion of predictive modeling, and it also mentions some of the more prominent vendors in this space. I'll also point out, however, that while predictive modeling has been almost exclusively the domain of armies of PhDs that know how to do this kind of Star Wars wizardry with their mainframe computers, the statistical software and the desktop computers are becoming increasingly more powerful. And if you've got even a master's prepared or access to a local educational institution that has good background, it is possible to. It's becoming increasingly possible to do this yourself, and it's turning out to be the usual contrast between build and buy, right? Do you want to buy it, or do you want to build it? Both have advantages and disadvantages.
Okay, thank you very much. Next question is more of a change management question. In a fee-for-service RVU-based world, providers typically are concerned when you mention a longer time with patients or less patients per day. Any suggestions on how to address this concern until payment reform truly happens?
I'll take a stab at this. I commented on living in an imperfect world. Without editorializing as to whether fee-for-service should totally go away, I think we should plan on coexisting with the fee-for-service, volume-based environment with an increasingly risk-based environment in the coming years. And care coordination can work in both of those environments. In the first, a volume-based model, if you will, I would argue that you will actually be more effective in delivering the right care to your patients and potentially even increasing your practice capacity if your patients are not having intercurrent needs that you have to step in and, to use Dr. Sideroff's term, pull coals out of the fire. So it might even be a process of enable you to increase the efficiency of your practice and achieve, for lack of a better term, larger volumes. I think the message is very clear for a risk-based environment or an accountable care environment, which is you have to have care coordination. You cannot survive in the new model of payment reform if you don't include care coordination.
Great. Another question related to care coordination. The specific care coordination slide that was shown shows the flow of information between providers. The register indicates that it seems to be missing a flow of information with the patient. We often treat them as a key member of their own care team and critical to developing their own care plan. What's your thoughts in terms of the patient-generated care plan versus the provider to the care plan, and ultimately a patient-centered approach where both the provider and care team and patient work together to devise the care plan?
It's a superb question, and I'll certainly be interested in hearing what Dr. Sideroff says as well. The build of patient connectivity, what might be called the patient portal, comes across as fairly low priority relative to the build of the electronic health record in the physician practice. So I think this question gets lost in the mix, which is, can the patient actually be part of their own care management? Long before we had computers, hopefully discussions occurred between physicians and the patients with regards to decision making. But managing a care plan is an iterative and interactive process, and the more the patient can engage with their own record, to be honest with you, and to see their lab data and to see the results of their studies in a real-time basis, it's positive feedback, and it actually makes educational materials, telephonic coaching stick better. So by whatever means possible, whether it's paper or electronic or what have you, the more of the patient's own data you can get to them in the course of execution of a care plan, the limited literature that's available would suggest the more successful you're going to be. But I think we also have to go back to the root of the question is what about the initial design of the care plan? And that's where you take into the fact what are the patient's wishes for intensity of care. To be honest with you, outcomes. These can be very ill patients with the prospect of dealing with their multiple comorbidities over a long period of time, and knowing what their expectations are for quality of life and intensity of care, I think is very important in coming up with what hopefully is a successful care plan.
I agree. A good care plan should have, quote, shared decision-making, unquote, which is a webinar maybe for another day. Very, very important concept. And however, I'll point out that this can shake the healthcare system to its roots. Imagine a patient, fully educated, deciding on their own that they would like to target an A1C of 7.5%. And many of the clinicians in the room will understand that. So should the primary care provider and HEDIS and all the other quality indicators that go into driving reimbursement, pay for performance, and accountable care organizations recognize that the patient decided that an A1C was 7.5% based on all the principles of shared decision making? If that's true, then it has huge implications for this idea based on clinical guidelines that every person with diabetes should have an A1C of 7%. Which may not be what the patient wants.
Great. Well, unfortunately, we are out of time, but I do want to thank everyone for attending today's presentation, certainly the entire PCC organization. Feel free to download Core Values, Community Connections, Care Coordination in the Medical Home for the actual white paper that this first of 3 sessions are based on. I did indicate on the screen currently that there's 2 other great presentations, one scheduled for mid-May, and one scheduled for mid-July. Feel free to attend and register for both of those. And again, I'd like to thank Dr. Sidoroff from Sidoroff Health Solutions, Dr. Crawford, and the North Shore Long Island Jewish Health System for the time today. This has been very informative, and I hope you received a lot of really good, helpful information from the event. Thank you. The webcast is ended. Thanks for joining, and have a great day.
The organizer has ended the session, and this call will be disconnected. Goodbye.